I'm Dr. Jerome Pagani.
And I'm Dr. Craig Joseph, and this is DocTalk.
The use of RPM, or remote patient monitoring, has increased substantially since the start of the COVID-19 pandemic. But what is it? At Nordic, we talk about RPM as a set of technologies that collect behavioral, physiological, and/or diagnostic data and then transmit it to a site distant from where the person or patient is physically located. This makes RPM distinct from telehealth, which we've discussed, and from digital therapeutics, which we'll cover off in a future episode.
In 2018, CMS unbundled CPT code 99091, pushing the door open to broader RPM use. This allowed providers to receive separate reimbursements for time spent on the collection and interpretation of health data generated by a patient remotely, then digitally stored and transmitted to the provider. As a result of the global COVID-19 pandemic, reimbursement for RPM skyrocketed with a 555% increase among Medicare beneficiaries alone. These technologies had already been shown to reduce ER visits and hospitalizations. Their use during the pandemic demonstrated that they could aid in reducing COVID-19 exposure while simultaneously facilitating disease monitoring.
So where should health systems look to use RPM? For the management of chronic diseases. Globally, 1 in 3 adults live with more than one chronic condition, and that number is projected to increase over the next decade. In the US, people with 5 or more chronic conditions make up 12% of the population, while in the UK, the proportion of patients with 4 or more conditions is projected to double between 2015 and 2035. Managing chronic diseases and their sequelae is a resource-intensive exercise in the US. It accounts for 90% of the total annual healthcare expenditure. RPM is part of a suite of technologies that has the potential to improve the efficiency of care delivery.
So is RPM cost-effective? Conclusive data remain elusive as program measures are dependent on the clinical context, investments, organizational processes, and reimbursement models in each specific setting. However, early data suggests that it can be cost-effective when used for the management of some conditions such as hypertension, COPD, and heart failure. A 2-year study of Medicare's chronic care management program indicated that through the use of RPM technologies, CMS has the potential to save millions of dollars, decrease readmissions, and improve chronic disease management education.
Healthcare organizations need a modernized data architecture capable of capturing and analyzing continuous data so that the clinical care team has actionable insights and not just more information. This approach to IT infrastructure also enables the integration of AI models that would further enhance clinicians' ability to manage disease, further elucidate underlying etiology, and analyze the effectiveness of timed interventions. New care models and workflows are needed to properly integrate these insights into care delivery and condition management. For instance, using RPM and telehealth in combination with a command center approach allows a small number of clinicians to monitor and care for a number of people. Collecting data using RPM technologies is a continuous step, not the end goal. As it becomes the norm in healthcare, we can expect both the delivery and the quality of care to change for the better.
So essentially, we make a decision based on how good we think you'll look in scrubs.
Are you doing med school interviews?
No. Yes, we are.
If you were, could I be dean?
Oh yeah. No, he can't.